Good morning, Dr. Manoj Chopda from Magnum Heart Institute, Nasik. Today we are going to do a right coronary artery CTO case. I'll just show you the case summary. Can we have a slide, please? Next. Next slide. Yeah. This is a basically 51-year-old male. He had an anti-wall MI, admitted at Magnum, and we did a PAMI to him to the LED diagonal, and there was a PTCA to RCA which is planned today. Basically, I'll show you the angiogram. Echo showed a anti-wall territory akinetic with LVF of 30%, LA mildly enlarged, RARV normal. Next slide, please. LED was a thrombotic 90% stenosis, LCX mid ectasia with 50 to 60% stenosis, and RCA is near total occlusion. If you look at the RCA, it's a tapered end at the occlusion. There is a retrograde filling from the LED collaterals. That segment of occlusion appears to be more than 20 millimeter. There is some calcium seen in the on angiogram, and basically if we look at the angle, it's more than 45 degrees. So this RCA looks like a CTO with an intermediate to difficult type. If we look at the JCTO score, I'll show you the angiogram. Next. You can see this is LED diagonal and the circumflex. LED, you can in the second view, you can see a collaterals filling the PDA PLV retrogradely in the second view. Next. Again, this is the LED diagonal. What we did, it was a LED stenting provisional with a kissing of the diagonal flow good. That's why we accepted the result. Next. And this is the RCA. RCA is almost 99%. Some TIMI1 flow. As I said, collaterals from the LED, and the lesion length appears to be more than 20 millimeter. And there is an angle more than 45 degrees. So JRCTO score, it becomes an intermediate to difficult RCA. And what I am going to do today is going to show you about how to do a robotic angioplasty in CTO case, and basically how to cannulate the guiding catheter using the RCA catheter, cannulating the RCA, then taking the wires, and basically we have a console here. There are 3 joysticks. One most rightmost is for guide catheter, midway is for guide wire, and this one is for balloons and the devices. This can be go antegrade, postograde, clockwise and anti-clockwise rotation of guide catheter, you can see. Then this is the forward movement, antegrade movement, and clockwise and anti-clockwise rotation. And there are 2 to 3 functions for the wire movement, that is a rotate and retract. For the if it goes into some branches, you can rotate and retract, and some other for the CTO there is a spinning movement and wiggling movement which we do with the hands. The same can be done with robotics, that I will demonstrate during the case. And this is only antegrade and for retrograde movements for the balloons and devices. So my colleague Dr. Amit Patel is there in a cath lab with a technician Pushpa. They will show you how the robotic arm is prepared, how cassette is loaded, and then how catheter is connected, and then I will show you how to cannulate the right coronary with a robotic help. Over to you, Amit.
Yeah, hello. This is the robotic arm. So this is a screen on which every step is displayed. So we have to just follow the instruction given by the machine. So this is the corridors. We are using this cassette. We have to install it. So we are attached to the slot. We have to just push the slot. We can hear the noise of attachment. This is a knob. We have to attach it. We can hear the click of the noise. So the instructions we can see over here. We have to open the rotatory cabinet. We just follow the instruction as it is given, right? The cassette is preparing itself. You can see the movements. The cassette checks the rotating arm. If everything is fine, the next message will appear over here. So the robot has asked us to tilt to the 30 degree for us to have an angle to the catheter, right? So they have asked us to load the catheter now. So we will follow the instructions. So there's a guide we have put in with the help of guide wire. So this is the co-pilot. We have to, so there is a, there is a slot for this co-pilot. We have to just keep the co-pilot over there. You can see the co-pilot over here. We close it. We can pull it down. So this is the arm we have to lock to the sheath, right? So the robot would have a control of the sheath also, right? So we are putting it down. You can see this is a sheath. One second. So I'll again do it. So the guide has not gone into the lumen. Just pull it back. So I'm pulling it down again. Yeah. So there is a lock over here. So we can have a guide attached to the sheath. So you can see this lock. I'll just lock it. So this is the lock position you can see now. So the instruction is now the cassette is almost prepared. So we are prepared with the cassette. There is information on the here. If you want to exchange any wires, guide wire, we have to press the button over here like this. We can, so the machine prepares itself for putting the devices, right? So now we can just put the wire accordingly, right? So we'll now engage the JR wire robot guidance, right? Over to you, sir.
Now Amit showed you that how catheter is connected to a cassette, and now this is the screen where you can see a catheter, guide wire and device. You can enable all, and that's how now you can see there is a screening catheter. We'll take a catheter down. Now this is the catheter moving. I have gone to a right coronary cusp, and I'll try to rotate that catheter with an antigrade movement. Yes, you can see the rotation. The way we do manually, the same way I am trying to do it with a robotic arm. Yeah, you can see now it's engaged properly. Take a shoot.
Shoot, Lou. Shoot.
You can see how I rotated clockwise, anti-clockwise, pulled it back, and now the catheter is completely fixed into the right coronary artery. We'll take the wire now.
So now we are going to exchange the device. So we'll press the load exchange device button over here. So the robot will allow, it's preparing to exchange, right? So it has asked us to open the cover. We are opening the cover. So this is the guide wire cover. We have to place the guide wire over here. This is for the exchange of the balloon, right? So we'll just move the nozzle. So that will allow us to have an access to co-pilot. We'll just put a wire over there with a angioplasty needle. There is a slot over here. So we push the needle, we'll removing the needle. Wire open. Right, so there is a rotatory knobs over here. We have to just place the guide wire accordingly, and we have to close the doors. So there are magnetic knobs attached on the cassette. So while that will control the movements of the guide wire. So there are magnetic knobs for which we can use that, so we can have a control of the knobs. Guide wire actually it won't wobble around, right? So there is a slot over here. We can use it to load the balloon over here, right? So it allows a very easy access to load the balloon over the wire.
सर करावे लागेल का रे सोडून देऊया ना.
So there is a holding knob over here, so that will allow us to hold the guide wire. So now we have a support of a guide wire that is holded by a knob over here, so we can directly push the balloon into the co-pilot, right? So we are pushing the balloon in the co-pilot, loading over the guide wire. So the cassette is holding the wire over here. So now the balloon is on. So there is a slot over here for the balloon. So we have to just keep the nozzle over here. So we are placing the wires in the particular positions. We can use it, right? So we are placing the wire in the right direction. We are closing the doors. Now the balloon is also loaded. The guide wire is also loaded. So we can the robot can have an access to both the things.
So Amit has loaded the wires and balloons. So now you can see a screen where you can enable that. There is a turbo button on this console. If we press it and move the wire, we can see on the screen wire can be taken up very well to the tip of the catheter. Yeah, now the wire has come and catheter has moved. I have adjusted the position of catheter with a catheter. Wire has gone into a side branch. I'll just pull it back. Now I have rotated the wire with anti-clockwise movement. It's difficult to push it. Now you can see the tip was rotated. Put the ROR negative technique off. Balloon support level. I'll take the balloon support down. Now you can see a balloon at the tip, which I am taking into the right. The ROR will use there, it will rotate. You can see that whatever the CTO segment or the occlusal segment we are able to cross with the ROR and the spin moments, what we see with the wire, what we do with the hand. I have used the robotics for that, and I am progressing the wire now forward. You can see I have gone into a PLV. I'll try to take the balloon down now. This is what the balloon has crossed the lesion, and I'll try to pull the catheter back. Catheter. I think I'll take a balloon slightly downward. Yeah, you can dilate it here. I think we have dilated the lesion very well. You can see a movement of a balloon very well moving, 1.258 balloon going through the lesion very well. I'll remove the 1.258 and we'll have to go with a bigger balloon.
बीपी देखो कितना है.
So now we have taken a 2.5 balloon. I'll try to
Pressure
move
screen
it
है,
to
एक
the
second.
tip of the catheter. I'll go to a distal part and try to dilate that. Check shoot and we are dilating in mid part again with a 2.5 or 8, 14 pressure.
स्लिप हुआ है.
Deflate. Dilate. Here one more dilatation. Okay. NTG Nicoran and shoot. We did a OCT in this patient. We can see a OCT run. Distally, it all looks a fibrofatty plaque. Can you run the OCT?
Run the OCT from distal
Yeah.
point.
You can see it's a very significant stenosis distal to the lesion also, and proximally where we did a balloon there is a dissection. We are coming forward, fibrofatty plaque more of, we have dilated with a 2.5 balloon, and total length come proximally. Yeah.
10-15 मिनिटं अजून एका साईडला लागेल. लेफ्ट मधली बाकी अजून.
Yeah, from here you can see lesion here tight, but again now this can be a point for a proximal placement, and the artery measurement there is around 3.6 and the 3.7 in two different angles, and distal it's around 3 millimeter. So total length is around 30 millimeter on this, but distally also the plaque is there, so landing zone I think will have to go down slightly. So it will be a 3.5 38 stent. We'll choose according to the OCT. We'll take a 3.5 38. Yeah.
We are taking a 3.5 38 onyx. Railing it down, just stepping the wire over here.
Yeah, this is what we are placing a 3.5 38 at a nominal pressure. It's a onyx. Trackability is good. And one good thing about robotic, when you are putting a stent, you just fix the catheter which doesn't move, and the stent, whatever the length is there, we are able to push it good.
Deflate, deflate, deflate.
Patient had a bradycardia, so I pulled out the catheter of the vessel, and I am removing the balloon again now. Yes, now balloon can be taken back with a turbo button and air. Yeah, balloon is out.
Stent is out, we are exchanging the stent.
We'll take a 3.5 12 balloon for post dilatation.
So wire is stepped. So we'll just push the balloon again inside the push pull. So once the balloon is inside, the monorail is inside, we'll just load on the cassette, balloon and wire too. And close the console. Now the robot can take a control.
Now I'll be taking a 3.5 12 balloon for a post stent dilatation.
Fine, I'm going up, sir.
Yeah,
So going up to the nominal pressures, 12,
18.
it's 14 now, 15,
Okay.
16. I'm down.
Just check distally.
So it's 10 boost again.
Yeah, we can go for 12.
So going up again. So I'm going up to 12,
Okay.
14,
Okay. I'm taking it back. Yeah, go 18.
So I'm going up. So up to 12, 14, 16. It's 18 now.
Okay.
So I'm deflating now.
Yeah, go.
Yeah, going again. I'm up to 12 atmospheric pressure. It's now 14,
18.
16, and 18.
Go.
Going up again. 12, 14,
16,
6.
18.
Stand boost.
Check. Yeah, check. Go 18.
Going sir up to 12, 14,
16, 18.
14.
18.
ठीक है ना.
Check. Check. Yeah, 12.
Going up to the nominal pressure 12.
Okay. I am removing the NC balloon 3.512. We have dilated the stent well at the 18 pressure.
You can see the turbo movement of the robot. It can just remove the balloon over till
Yeah.
the monorail, right? So once the monorail is there, we have to exchange the device. So you have to press the button over there, open the cassette, step the wire.
Yeah, we'll do one was OCT shoot and come out.
Yeah.
Distal vessel is good. There is no edge dissection. Their stent apposition looks good. Area achieved is MSA 7. Here apposition is good. It looks good. Here it is good. Apposition is good.
I दिसतं ना ते.
Area achieved is good. Here some stent apposition was not good. I think we'll just dilate with a show it at the proximal part again. Yeah, there where the stent apposition is not good. Just go down.
Stand up position नाही येते दाखवायचं. Show the 40.
Go down.
44 mm distance. That yeah.
Yeah, there.
Yeah.
Okay. I think we'll have to dilate with a 4O balloon.
Yeah. Size कितना है? What is the size over there?
There is a branch. That's why we are able to see that.
Yeah, probably it
rotate.
can appear also because of that also. Yeah.
Rotate it in a
360
not
degree
this
rotation.
OCT circumferential view.
Rotate it.
Not that. Oh, go yeah, more angulation.
Yeah, otherwise it's
More
okay, probably just
angulation.
because of the branch it is showing
Towards
like
right
that.
side. As
4
proximal
4 right?
stent is
4
showing
12.
some unopposed area and hanging
NC or SC?
struts, we'll go with a 4O balloon to dilate the proximal part so that the stent apposition will be good.
Negative. Double negative.
Yes, I am enabling all the. I am taking the 4O balloon down.
मैडम वायर बोलो पीछे लेने के लिए.
Yeah, I have taken the wire back. I am taking the balloon down. Yeah, this is a 4O balloon. Okay.
Nominal. Yeah, inflated the balloon up to 12.
Yeah.
Going, sir, up to, I'm on 8, 10, 12,
18.
14. Going down.
Just check. Yeah, check. Go. 18.
Up to 14, down.
Up to 18. Just check. Go.
Yeah, up to 12.
14.
Yeah, 14 atmospheric pressure coming down. नहीं दिखता क्या? Yeah,
This
the
is
case
what
is over, so we'll
we
end the
did
case over
today.
here.
RC
So the robot
CTO
will
lesion.
direct us to do.
Basically, wiring was important.
to
We
open
started
this.
with a BMW wire. We then upgraded to the XTR wire, and then we could
You have to
cross
unlock
the
this.
lesion with the spin movements with the
Once it's
robotic help.
unlocked,
What we do with our fingers, the
Yeah, put
same
it-
thing we
yeah,
could do with
pull
the
it.
robotics, and that's how we cross the lesion. We took a 1.2508
Pull it.
balloon to dilate the
Right,
lesion
it's okay.
first, and then 2.512 balloon was taken to dilate the lesion properly, and after
Right,
that
so
we
can
did a
just
OCT. It showed a lesion length of almost 38
remove the
millimeter.
balloon and
So
the
we
guide
took a stent of
wire.
3.538 onyx. We deployed it proximal to mid, and
to
it was
close this.
deployed well. And post stent dilatation was
Small
done.
button. So only thing you have to change this cover for
Post
every case.
stent
Just
and the balloon dilatation, we did a OCT which showed that in proximal part the stent is not unopposed well, and there were hanging struts. So we measured the artery there, that was almost 4 millimeter. So we took a 4 by 8 millimeter balloon and dilated the proximal to mid segment with 4 by 8 balloon for a 14 atmospheric pressure, and the end result was good. And this is how the RC CTO we could do with a robotic arm, and you could see how we demonstrated the console, 3 joysticks, guide catheter movements, wire movements, balloon and the stent movements, and that's how we are regularly doing angioplasty with a robotic arm help. Basically, most important thing is I can sit here and do my procedure completely. Here the 38 millimeter stent was used. You could see that the catheter and wires can be fixed once you want to uh, pass the stent. Stent trackability was good as the guide catheter wires were fixed, and we could put a 3.538 stent easily. And that's how we completed this procedure with a robotic help, and that's a new technology. I think more and more centers need to do work. In last 4 years, we have done almost 350 cases. Initially, we started with a type A lesion, and now we are doing type B, type C lesions, bifurcation, long segment stents, CTO lesions successfully. In acute coronary syndrome also, we are using robotics in many cases, because wherever we have to put a long stents or ostial stents, I think the ostial stents 1 millimeter movement is very good. So placement of stent at the ostium becomes easy. Long stents, catheter wire can be fixed. That's why we can put a 48, 50 or 60 millimeter stents easily. We have done a 1 RCA in acute coronary setting, infeval MI, post infarct angina, and 60 millimeter stent was put with a robotic help. That was the first case reported in the world, and that's how our robotic program is going well. I think the robotic arm preparation, cassette placement, and then the loading of the guide catheter wires requires training, and we have a team now which does this work very well, and that's how our robotic program is going very well. Thank you very much.